I think चौहान सर अपने लिए कम बोल रहे हैं. I am testament to organizing few CMEs, and I feel it's a severe headache organizing people, organizing funds, getting people, and 1000 CME sir salute के अलावा तो और कुछ है नहीं. Nothing short of that. Week after week, it's phenomenal feat, and I am honored that I will be part of that 1000 CME. With that, today's topic is going to be recent advances in radiotherapy in the treatment of cancer. Fundamentally, there are three pillars of cancer treatment. There are many more now, but fundamentally there are three pillars. One is surgery, second is radiotherapy, third is chemotherapy, which is now targeting thousands of things. Radiotherapy is a non-invasive way of treating cancer, and without it, there are many a times I think oncology world will come to a standstill. And we have Dr. Vikas here, who is going to take us through what are the newer and recent advances in the field of radiotherapy in the treatment of cancer. Thank you so much, Dr. Vikas, that you are here, and we would be honored to learn from you. Thank you. Thank you.
Okay, no problem. Hi, good evening everyone. Thank you so much for coming, and it was a privilege to attend such a big number of eminent physicians here. So, sir introduced me as a radiation oncologist. So, sir introduced me as a radiation oncologist, but before radiation oncologist, I am a physician, followed by clinical oncologist, and then finally I am a radiation oncologist. Radiation oncology is just my specialization, but overall I am a physician first, then followed by clinical oncologist. So clinical oncologists are those who guide the patient about the treatment chart. Like Amish Vora sir, maximum of all of you are sending the patients to Vora sir because he is practicing in South Delhi. So same thing, if any patient comes to my clinic, then accordingly what treatment sequence is there, we decide. I'm poor in the PPT, so I'm not here with the PPTs. PPT will be given by my colleague about the techniques and other things. Before that, I just go through some overview of the radiation oncology. So, like every branch, every pillar, what Vora sir told about, there are three main pillars of the oncology, that is medical oncology, surgical oncology, and radiation oncology. Every pillar is developing and evolving as such in every decade. So, for example, for the medical onco, now instead of a direct IV or PIC line, we go for a chemo port first and then followed by chemotherapy or whatever we give for the systemic therapy. The same thing for the surgical point of view. Now we have the study here, that is a robotic surgery. So that is a now hot topic. Every hospital wants a robotic surgeon and a robots. So that is there in the surgical, and the same thing in the radiation also. We have modern linear accelerators. Few hospitals now coming up with mRNA, they are coming up with gamma knife, they are coming up with proton also. Now talk of the town in Delhi is proton therapy also, which soon the Max and maybe Fortis and Apollo will come, and later on maybe Manipal or other hospitals will also come. So all things are evolving. Every decade, everything is evolving with changing practice. We are coming up with more and more skills, more and more techniques. So the main thing is about this adapting these techniques. Like everyone in your era, when used to send to our radiation oncologists, they used to practice on Bhopal or they used to practice on a normal linear. Now time has changed. Now if we see if any patient comes to us, then according to the patient we tailorize the treatment. Like mainly if I talk about the geriatric patients, mainly those who are 80 plus, those who can't afford, those who can't take chemotherapy, those who can't go for the surgery. still the radiation is an option, and still we can give radiation. And believe me, radiation is the one which have the least side effect of all the three things. Surgery have its own complications, medical chemo have own complications, and radiation is still least. If you can ask Vora sir, that it is really how much we evolved as such. So especially for the geriatric patients, or especially those who are 70, 75 plus with multiple comorbidities, our radiation is still a boon for them. So we always think for the patients how to cure the patient or how to control. If there is a word between cure and palliation, that is control. So that word is not there in the books. That word is not there in the institutes. Institutes like Cmes, Rajiv Gandhi or whatever, but that word, control word, is there in the corporates, that word is there in the independent practice. Everybody should know that thing. And we try that also, because still around 30 to 40% patients come in that category. Now, if we talk about the management point of view, stage 1, stage 2, anybody can treat. It's about the stage 3, stage 4, for those with multiple comorbidities and multiple like things which is not easy to treat. So that all me and my team learn. So we are in total 5 radiation oncologists working with me. Other than me, I do have around 17 years of experience. Other team have around 10 years of experience. Dr. Hemant have 10 years of experience. Other than Dr. Hemant, I have 3 more radiation oncologists. Almost all of have around 10 years of experience. So I developed my department like that. I don't develop like one senior doctor and others all SRs or like first year or just 2 years of experience. I don't develop like that, because it's about the patient care first. So we work together not as a senior or like a junior. We all work together as a colleague. And this is about the radiation part. Other than radiation, we have surgical team. That's all of around almost 25 to 30 surgeons we have. All with the DMGs, disease management group. With that, we have a great plastic oncosurgery team, which last month they done more than 100 plus flaps. So that was like a big achievement for the Delhi. In one hospital they done like that. Same thing, my department last month we crossed 110 new patients recruited for the radiation, and everyone took the treatment very successfully. Though our surgeons, they done almost only 100 surgeries, but we done around 110 patients for the radiation point of view. And that was the highest in Delhi NCR last month that we achieved. So, and that was only on one unit. And it is not possible because of me, because of Dr. Hemant, or because of only my team. It is all effort by everybody, from the management side, from everybody's side. So that's how we still plan, we still want to expand more, we still want to give more and more care to our patients. So I just need a support from everybody. Everyone can connect with me for any type of cancer. Those who are in Palmo, they have to, we deal with the lung cancers. If I'm not able to handle the lung cancer first, then I send my patient to my medical oncologist. Then master medical oncologist will plan everything. After neoadjuvant chemo, then we plan for a CTRT, or same thing like others. If a surgeon go and operate for any kind of the tumor, then adjuvant treatment we go for that one. Gynae, mostly endometrium or cervix or any other part which we treat very well. In OP we have very limited role of radiation. And the same thing like ENT persons. ENT doctors, they all are very well connected with me in my West Delhi part. So they send us, once they diagnose the patient, they send us patient for the treatment, especially for the larynx. So that by radiation we try to save, we do voice preservation only through the radiation, that is with hypofractionation. And the main point behind how I am able to treat so many patients in less time, that is I am adapting the new technologies like in the breast. we are doing fast forward, UK fast forward trial. We are doing breast cases mostly early ones in only 5 sittings. We are not treating in 15, 20 or 25 sittings. When I started my journey in radiation, my teachers, those my guides, co-guides, they used to treat in 25 plus 7, 32 sittings. That is around 6.5 weeks. I am treating in 1 week. So that's how we are adopting the technology. Same thing for the brain, like adenomas. Today one patient after 6 months he came back for the follow-up. So that was a very interesting case, pituitary adenoma, which I treated 6 months back. He is from OT, major technician from RML. Now he is absolutely fine. Like the tumor was sitting on optic eye. That time he was not able to see from one eye also, that there was a dimness in the vision, but now our visual perimetry is showing perfectly well and he is doing his work very well. So that's the art of radiation oncology. Everyone not that easily get. I am so fortunate enough, I worked at so many places where all the technologies, all the hospitals like FMRI, Max Saket, and before that I started my journey from Jaslok, Mumbai, and I was at Cmes. After that, I started my own practice after 10 to 12 years practicing under some mentors of top-notch mentors. Then I started my practicing, and now this is my 7th year independent practice. And in 7 years, I also trained my other radiation oncologists, and they are equally working with me, and they never leave me. So Dr. Hemant is there with me since 3 years. There are 2 more doctors, they are there with me since last 7 years. So that's how we work. That's how we make the team. So I am here to make the team and to interact you and to treat the any patient. If you send any patient to me, so you will be actively involved for that. Presently, one of the patients of Tulsi sir is going on. So we both, I am not alone treating the patient. Patient is mainly treated by Dr. Tulsi sir only. But I am supporting. I am interested supporting from the back seat. That's how we treat. So I just invite my colleague Dr. Hemant for just a small presentation about the techniques and in the radiation. Later on we'll discuss about anything, whatever you want to ask, you can ask us directly as a question and answer. Thank you.
Dr. Hemant Pandey, I asked him, how can I introduce you? उसने बोला सर एक ही चीज बोलना, मैं दिल्ली का लड़का हूँ। So I think दिल्ली का लड़का Dr. Hemant Pandey, consultant radiation oncology Manipal Hospital. Over to you, Dr. Hemant.
So good evening everyone, and thank you all great doctors and physicians for attending here tonight and supporting us. So I am going to present a very brief introductory slides about radiation therapy, modern radiation therapy. So how it works and how we plan the patient and how we deliver our treatment in a very brief introductory manner. So this will be an interactive session. You can ask any question in between if you feel like. So radiation has been effective treatment modality of cancer since more than 100 years. Maybe most of us will not be knowing about the radiation, how it involved in cancer management. And more than 60% of all cancer patients, they need radiation therapy at some point of their treatment journey. So what are the indications of radiation in any cancer patients? So radiation will we implement radiation in case of neoadjuvant treatment, like in definitive setting or in adjuvant setting, palliative setting, and also with concurrent with chemotherapy setting. So neoadjuvant means like if we give radiation before surgery or chemotherapy, like in case of sarcoma. So because we are delivering radiation, then the patient go for the surgery. So biologic basic of radiation therapy. So most of us wonder how the radiation therapy works. So it's like nothing but we deposit energy through the photons or protons or in the way of gamma radiation. And it works like how chemotherapy works, same manner like chemotherapy break the DNA and cells die subsequently. So radiation also work in the same fashion. So the only difference like radiation also affect normal cells, but normal cells they have intact their cell repairing mechanism, so they get repaired rapidly, but the tumor cells they have compromised cell repairing mechanism, so they die after radiation or chemotherapy. So radiation therapy works like it's like a double, a double-edged sword. So in case like you can see, if we increase the radiation dose, there will be more tumor control probability, but at the same time there will be more normal tissue damage. And also if we reduce the radiation dose on any particular tumor like lung or breast or anything, so if you reduce the radiation dose than the prescribed recommended dose, there will be normal tissue toxicity, less toxicity, but there will also be less tumor control. So it has to be balanced very accurately between normal cellular toxicity and adequate dose to the cancer cells. Radiation therapy techniques, like we have now treatment modality with like linear accelerator based radiation therapy, radioactive sources based radiotherapy, and particle based radiotherapy. So linear accelerator, what we have in our center is linear accelerator, and what also most of the center in Delhi NCR have are also linear accelerator. So linear accelerator provides radiation treatment in many manners like 3D CRT, IMRT, IGRT, SRS, MR, FSRS, SBRT, and so on. So in this slide you can see, like if we plan a treatment, cancer treatment with 3D CRT, there will be more toxicity. And if we plan in decreasing manner like IMRT, IGRT, SRS, FSRS, SBRT, there will be least toxicity to the normal tissue and tumor control probability will be more. Other manner of radiation therapy is like radioactive sources like gamma knife and telecobalt. Telecobalt machines are now isolating. You can hardly find anywhere in Delhi NCR this telecobalt machine. Gamma knife are limited to few sectors because this machine they uses radioactive cobalt, so their maintenance and expenses are more in comparison to the linear accelerator. So this gamma knife also is like limited to very few centers. The most advanced radiation modalities are particle-based therapy, which are proton therapy, carbon particle therapy, neutron therapy, and boron neutron capture therapy. So now we have in our country proton therapy. We don't have any carbon or neutron therapy. Proton therapy is limited to some centers like TMH and Apollo, Chennai. So evolution of radiation therapy, if you see like in 90s, 40, 90, 50, 90, 60, there used to be 2D radiation therapy in which clinicians used to take an X-ray of that particular area and they used to draw the tumor on those X-ray and they used to give parallel opposed field for that particular tumor. In that case, there used to be maybe more toxicity to the tumor because there was very least conformity. Then the radiation therapy has evolved many-fold. Like after that, there has come 3D CRT, then IMRT, VMAT, IGRT, particle therapy, and now that adaptive radiation therapy. This is the standard modality now. What we are practicing at our center, adaptive radiation therapy, in which what you do, suppose you have planned for some patient for 30 sessions of radiation therapy. So after 10 sessions, there will be reduction in size of the tumor. So we again replan the whole thing, like everything. We do the CT again, we do the contouring part again, we do the beam management, arrangement and everything. We redo the whole things right from the beginning. And again after 20 sessions, the tumor size again reduced. Then again we replan the whole thing again. So that is called adaptive radiotherapy. So in 1920s there used to be this machine, kilo voltage X-ray machine. So this machine is like you can find only in museum. This is not being used anymore anywhere in the world. And telecom machine in 60s, 70s, this machine used to deliver gamma radiation with cobalt. So this machine used to call as telecom machine. Modern linear accelerator, this is what we have at our center. This is true beam STS machine, this is the latest machine we have at our center. Then, I don't think any other center in Delhi NCR, hardly few centers they have this true beam STX. I'm quoting again STX. Means this machine has capability to do all kind of treatment like brain tumor, child pediatric tumor. We do SRS, SBRT with this machine. All latest treatment modality can be delivered with this machine. So radiation oncology team is like coordination of many teams like radiation oncologists, medical physicists, dosing metrics, radiation technologists, and then radiation oncology nurses. This team they work all the time in the radiation oncology department. Besides this, we also have that like radiologists, pathologists, role of many other modalities. So what services we have at our center are 3D CRT, intensive modulated radiation therapy, image guided radiation therapy, and BMET, SRS, SBRT, electron therapy also we have, and motion management RT like gating, DIVH, and active ABC, active brain control. So 3D CRT we hardly use at our center because it has many much toxicity, so we don't use 3D CRT. Just for some palliative cases we use it. Otherwise, all the time we use IGRT, VV technology at our center. So we have this True Beam STX. It has like 120 gigs high definition MLC. So this if you will see this one, this diagram, this is multi-leaf collimator. So these are all leaves which are 2.5 millimeter thick and 60 on this row and 60 on this row. So they move in coordinated manner and they take the shape of tumor from all directions. So this machine is it has like X-ray of energy 6 megavolt, 10 megavolt and 15 megavolt energy X-ray we have. So using those high energy X-ray we can treat any kind of patient like thin to thin and like very obese patient also. And it has flexible imaging tool like CBCT. This is cone beam CT scan we take on couch. Before treating any patient, we do a CT scan and we match those CT scan with our RT planning CT scan. Those are called image guided radiotherapy. So we do point-to-point matching before delivering the treatment. So in that, if you do that thing, there will be no or least radiation toxicity. So this is the workflow, how we plan the patient. Once the patient coming to the OPD, we see the patient, stage the patient, and accordingly if the patient need chemotherapy, first we send the patient to the medical oncologist. If the patient needs surgery first, then we send the patient to the surgeon. And this is workflow in our department, how the workflow moves. So the first, like if the patient is head and neck cancer, suffering from head and neck cancer, we take the patient to our department, we make a mask of this head and neck area, and using this mask we do the CT scan for the RT planning. This is the CT scan on which we do the RT planning. We contour every organ slice by slice on that CT scan. Then we do the 3D model generation, and then we do the planning team arrangement, dose distribution analysis and all. Then we do the quality assurance of the patient on dummy. First we do on the dummy, and if we find that the plan is accurate and very accurate and sophisticated, then we deliver the treatment. So these are some examples of patients which we have treated recently at our center. I would like to show them. So this is the VMET volumetric modulated arc therapy. We have used for a single lung patient. This patient was very old, frail female patient. So she was not like candidate for surgery, and she was also not a good candidate for chemotherapy. So we selected this patient directly for the radiation therapy. And we planned for radiation therapy for this patient. And this is the gross tumor disease, and this is spinal cord, both side lung and heart. So we planned this patient with the volumetric modulated arc therapy, and we treated her, and she responded very well. So this plan is before. This is the plan we have used with the VMET like volumetric arc therapy. And if we compare with this VMET plan with IMRT, this is intensity modulated radiation therapy, which is a little inferior modality to VMET. So here we can see lot of dose periods which we don't see in the VMET modality. There is no dose spill to lung, heart or spinal cord. So normal organs are completely spared using this modality. In comparison to this modality, if we use IMRT, there will be lot of dose periods in the heart and lungs. So VMET is superior modality, and most of the time we use that VMET in our center. Subsequently, this patient, this adaptive radiotherapy, I was speaking just few slides before, we do adaptive radiotherapy in our center. So this patient was replanned again after 20 fracture. So this was the gross tumor after 20 fracture. Here we can see the tumor size has almost reduced by 50 to 60% after radiation. And this patient was treated only with radiation since she was not able to tolerate surgery or chemotherapy.
So this patient not able to treat chemo because earlier she was, if we notice here, she was a breast case. That time heavily treated for that. Then implant was there. Then this is the second primary. So that was the for the CLR. So we treated this one only by radiation, and patient is doing very well. So that's the art. Where we can't use other modalities, at least we can use one of the treatment given, radiation.
So again, after 20 fraction, we do again the replanning, and here we can see that after 30 fraction, the tumor has been gone almost completely, and there is no dose spares to the heart and lungs. So again, this is example of VMET in case of CA prostate. So VMET, you can see the conformity of the radiation dose, how conformable it is, and confined to just to our target, avoiding the rectum, bladder and everything. This is the urinary bladder. You can see the rectum. Those organs are completely spared using this VMET model. And this is IMRT compared to, if you compare IMRT in respect of VMET. So here you can see more dose periods to the bladder and rectum. So we are at our center, no matter what, we almost every time we try to treat patient with VMET. This is a case of left breast. So we have used here DI-based technique. This is deep inspiratory breath hold. This is kind of gating. So we ask the patient to hold the breath, take the deep breath and hold it. And at the same time, when our target area is far away from the heart, we shoot the pump. So if doing this thing, we can completely spare the heart and lung from the radiation. And why we are doing this technique? Because nowadays breast cancer patients are being cured at large scales, so their life is very prolonged. In that we don't want the patient to die with heart very long. So we are using this technique GIPH to reduce dose to the heart and lungs. So this is same patient with the IMRT. Here we can see spillage of dose to the lung. Most of the dose is going to the lung. Here compared to this VMET modality, where there is no radiation dose to the lung and heart. So we also do stereotactic radiosurgery at our department, since we have the latest machine, Trubin variant 2 STX. So this is one case. This patient, a female patient, she was from Agra and she was admitted at our hospital with brain stem angiosarcoma. So this the color thing you can see just sitting above the brain stem. So she came from the Agra and she was admitted in ICU. She was in comatose status. This area they received very high dose in per fraction compared to this blue area, which received a little bit low dose to the lymphatic drainage chain at the same time. So this technique we call dose painting or also simultaneous integrated boost. So this is very sophisticated and advanced technique for the head and neck, where we spare our normal tissue very excellently using this technique. This is again another picture of pelvis, where we see cervix, and using VMET technique you can see the conformability of dose, how conformable the dose is, and how we are sparing the bladder and rectum. So, and this is also again a head and neck case, where you can see this is parotid sparing technique. So again with IGRT VMET technique, we nicely spare the parotid, because head and neck patient, their most common complaint after radiation therapy is dryness of mouth. So using this technique, we are excellently avoiding the dryness of mouth, and we are 100% sparing parotid to all our head and neck patients. So these are all our console films, console areas where technicians are sitting and they are taking image. This is cone beam CT scan, and this is the radiotherapy planning CT scan. You see, we have matched point to point this CT with our radiation planning CT scan. So after, it's like we deliver, this IGRT is not like a laser gun. Like first we put the pointer and then we shoot the bullet. So this is how it works. So this is again picture of our console, and how we are doing this motion management. This is ABC, what we have mentioned few slides before, with active breath control. So what we do here, we do this abdominal compression in case of carcinoma liver or lung to restrict the movement of internal organ, so that they can be spared nicely, and dose distribution to our organs will be more conformal, since the target will not move. So this is how we treat a case of medulloblastoma at our center. In medulloblastoma is pediatric, commonly pediatric to brain tumor. Yet there we have to irradiate the whole brain and spinal cord all the way till the S2. So in that case we need very high precision radiation therapy. In that case we use VMET, image guided VMET technology. And doing that thing, we can easily spare this all the normal organs, because the child has to grow further. So we don't want to spare, we don't want to radiate normal organ with a high dose of radiation. So this is how you can see we have spared normal organ by treating our necessary area, all the spinal canal, spinal cord and the brain. This is the electron therapy modality. This is the collimator, beam collimator. We use to guide the electron beam to the target. So this is very close treatment and superficial treatment. It hardly has any side effect. Effectively, it has no any side effect apart from the a little bit skin reaction, grade 1 skin toxicity. It has no any other side effects. And thank you all.
I just want to add a few points. See, whatever the techniques here explained by Dr. Hemant, these techniques are everywhere in the Delhi. Almost like 35 plus centers are there in Delhi NCR. Everyone are doing, but what makes us apart, that is, one is adaptive radiotherapy. That means if we go for a radiation for 30 or 35 sittings, mainly for the head and neck, because most of the cases come of head and neck. If we treat around 100 patients, 60% are head and neck. So what we do, if there is a loss of weight, if there is a delineation, there is some issue with the matching, then we go for adaptive radiotherapy. We do offline adaptive radiotherapy. Sometimes we try to do online, but we don't have right now. The new machines are coming up with the online also, but we are not dependent on machine. So I feel very bad whenever my colleague or any of my patient asks me, sir, which machine you have. So my dialogue always is like that कि फरारी सबके पास होती पर चलाना सबको नहीं आता है. So it is not about the machine, it is about the how well we use that technique and how well we are skilled for that. So for adaptive, like we do offline adaptive, because now the machines are coming of double the cost and they are charging for that, and the hospital is also charging. Hospital also say कि instead of charging for 3 lakhs for normal package, for that, for online adaptive you charge for 6 lakhs, 7 lakhs. But same thing we can do offline. Offline means at every 10 fractions we go for an CT simulation and we check our first day simulation scan, we match it. If everything is outer surface is absolutely okay, then we continue with the same treatment. Otherwise, we again change the plan from the starting onwards, and the remaining fractions we do like that. So this just a brief about the adaptive thing. In the therapy also, we strictly follow about the bladder protocols. So what bladder protocol is? See, if bladder is full, that means when patient is lying down in a supine position, that intestinal loops will go up. So that will help to the patient. There is no scattered dose go to the loops, and ultimately patient will not have complaint of diarrhea. Patient will not have complaint of any bowel alteration. So that is a big relief for a patient, because for long treatment for 5 weeks, 6 weeks, if nutritional things something goes bad with the patient, then treatment definitely we have to stop the treatment in between. So that's very important. So most of the radiation oncologists, what they do, they just use that technique. They just try to treat the scan, but we don't treat the scan. We treat the patient. That's how. That only I tell my colleagues, don't treat scan, treat patient. That's the most important thing. And always we have in our mind, do not harm the patient, just give whatever the best we can give. Sometimes we have to refuse the patient. Many times I refuse, कि नहीं ये नहीं हो सकता, नहीं कर सकते. So the patient also asks, आप क्यों नहीं कह रहे, वो दूसरे वाले ने कहा है, वो कर रहे हैं, आप क्यों नहीं कर रहे? Because I know that thing, what's the consequences of radiation. The patient don't know. Patient is just it's the first interaction and the last interaction with the radiation oncologist. But that we know, that I can make understand to my referring doctor, but I can't make understand to the patient also why we refuse for some time for this particular treatment. It's very hard for any clinician to refuse for the treatment, but many a time we refuse. For example, mainly for GBM, if we treat patient twice, patient come third time again also with the regrets, we don't treat. Why? Because it can cause a big chances of brain necrosis. So it's of no use. Then we send that patient to Vora, sir, please give bevacizumab or whatever he want to give. A patient we hand over to him because he is the right person for that. So like that, everything in every site have something, and every patient teaches something new. So all the patient, either it's not about the head and neck है तो बस वैसा हो गया. It's not like that. अगर सर्विस वाला है तो वैसा हो गया नहीं. Even my gynae colleagues, they know very well what kind of the anatomies we see during our clinical practice. So same thing we also go through that, because we do the brachytherapy. So brachytherapy is not explained by Dr. Hemant here, because we have very limited time. So in the brachytherapy, we treat the patient by putting applicators inside the cavity. So we do that. We do intra-brachytherapy also. In sarcomas, my surgeon open the case. When they know they're not able to take clear margins, then they call us. Please come and put your brachy applicator so that we can treat now intra-op, and then we'll close it. So same thing like extra corporeal radiation to the bone. If we want to do some sarcoma, we want to treat some sarcoma, we want to implant that bone again to save the limb. So we just give radiation to that bone only. 50 grays, single fraction, within half an hour, immediately send that to the OT. Bone is implanted, sterile from the tumor, and then we implant. So like that. So it's not about one radiation oncologist, it's about the teamwork. It's an onco umbrella. It is about the radiation, medical, surgical. Other than that, onco, psycho, and our physiotherapist, our oncopathologist. So there are so many things involved. And above all, everything, the most important thing is the financial thing, financial counseling.
Dr. Vikas, finances, I would request, let them ask you about the finances.
Yes.
If there are questions, I think it would be more this thing.
Yeah.
So let them ask the questions.
Yeah, sure.
Okay, thank you, Dr. Vikas. Dr. Vikas and Dr. Pandey have promised that we'll give them they will give us another CME if there is a question from every table. And I don't know, someone leaked the news to Dr. Vikas that इस वाली फोरम में ना लोग तो शुरू में बहुत होते हैं, लेकिन जब तक क्वेश्चन आंसर सेशन शुरू होता है तब तक जो है सिर्फ डॉक्टर तुलसी और डॉक्टर काबरे रह जाते हैं। तो इसीलिए वो सारे क्वेश्चन जो है खुद ही आंसर कर रहे थे। डॉक्टर बोरा ने कहा कि यार कुछ तो हमें भी यार रोल दे दो यार, तुमने बुलाया है। ठीक है, तो अगर हर एक टेबल से एक ही सवाल आएगा तो अगली CME पक्की है, अगली CME पक्की है। Therefore, I would give it to Dr. Vora to set the context for his role as a moderator.
Thank you, sir. I will not ask questions, but I will share, I think, the importance of radiotherapy in cancer. If you start, like I'll give you 4 or 5 subsets. Hypopharynx, larynx, upper 1/3 of esophagus, cervix, early stage prostate cancer. 5 subsets. Radiotherapy is not an alternative to surgery. It is the treatment of curing the cancer of these 5 subsets. Okay. With that, I would set the ball rolling, and Chauhan sir, rather you go first, or Tulsi sir, you go first.
No, I'll go to Dr. Poddar first, because you see, Dr. Amish, you would have realized it working in oncology. Your accounts have to be very strong. He is my accounts man. So,
Dr. Amish also said, see, prostate is one cancer where radiotherapy can be curative, it can be given as adjuvant therapy, it can be given in metastatic disease also. It can be given as external beam therapy, it can be given as brachytherapy, as you rightly know. So, when you decide that we will not do surgery, radical surgery, because surgery for prostate cancer is a radical prostatectomy, is a very major surgery. With robot, it has become easier, but still there are a lot of morbidity. So when do you decide, is age the factor, or when do you decide that we will give radiotherapy, not surgery first choice?
Dr. Vikas, sorry, just one hint. This forum actually have a lot of questions.
Yeah.
So if your answers are short, we can move on to the next question.
So it's totally depend on the patient's choice. And the next one is if our surgeon send us, then only, if urologist have the case, then only we able to treat. Otherwise, if patient directly comes to me, then only I can say whether which one is better. It is not about the age, it is about the patient factor. If patient is fit, there is no comorbidity, then both the modalities are equally effective, and I give both the options, totally depending on the patient. But if the tumor is extra capsular extension is there, then it's always better to go with the radiation instead of surgery when patient is 70 plus, because that patient even after the surgery need radiation at some point of time. That's all.
Sir, I would just add, you asked a very, very important question. And in a year, I lose 6 times the battle with the neurosurgeon.
Yes.
2 scenarios where RT should be better than surgery for prostate cancer. One, in a young, fertile patient having a good sexual activity. whether you do a robotic surgery or do a radical prostatectomy, the nerve sparing surgeries kitna common hai we don't know. The importance is more compared to radiation. So when the patient is active, nobody talks about these factors, and one should know about these factors, that the sexual importance is less with radiotherapy compared to surgery. That is one. And second thing is one particular risk factor where intermediate, unfavorable, actually radiation plus hormone is a shade better than surgery. ये बोल के थक जाता हूँ सर, पेशेंट सर्जरी करवा के आते हैं मेरे पास. Since आपने ये सवाल पूछा, I thought I will tell you that.
Yeah, because urologists don't give the chance to talk about that thing. That is very unfortunate, because if we talk about the US practice or any other country practice, medical oncologists, uro-oncologists and radiation oncologists all three sit together and then they give the option to the patient. In a protocol for that.
Can be bias also in UK. When we were doing MS surgery, we were told that in UK or US there is lot of bias. One country favors surgery and one radiotherapy. Is it still true?
Yeah, it's still there. It's still there. US go with the radiation more and UK go with the surgery more.
Thank you.
Doctor, अभी आप डॉक्टर जसबीर को जाना था, इसलिए सवाल पूछे नहीं.
Sir, we have a patient who has been done a biopsy and proved adenocarcinoma. So I think surgery is a must.
Adenocarcinoma where? Prostate.
I think the surgery, we have planned a surgery earlier, then chemotherapy later on. What is your suggestion? Should he have a chemotherapy earlier and then?
See, chemotherapy we give only in a metastatic setup. And for chemo, sir, is better to answer. Because chemo we don't give as such in a prostate cancer which are just limited.
In this patient there is no metastasis.
So why to be chemo? Chemo goes only in the metastatic setup. Only the ADT will be there, androgen deprivation therapy. That is we should give. That is hormonal. We should start with the hormonal, and after 2 to 3 months, then we should plan either for the surgery or radiation. Correct? So first patient should go to the medical oncologist for that, and then we should proceed with the things.
Sir, I think patient quality of life is very important. So if any prostate patient is going for surgery, they will have lifetime urine dribbling in a child dysfunction.
No, I am not totally agree with you for that, because if a good surgeon is there are so many good uro-onco surgeons in the town. I'm fortunate enough I work with so many of them. So it depends what the ideal condition for the patient. Sometimes I say if it is very limited, then I say okay, go with the surgical point of view. Then I say them. And sometimes I fight with my urologist also कि नहीं इसमें radiation होना चाहिए. There are 2 urologists, they send one father and one other one is uncle to me for the radiation. 2 urologists, so I respect them at least.
Sir, Colonel Vipin, he would like to ask you a question. He's a urologist by the way.
I agree with you. The first contact is always with the surgeon, neurosurgeon.
Correct. Yeah.
The doctor doesn't want to share any, he wants to investigate, diagnose, and then there is a hormonal therapy. So definitely radiotherapy comes later in his scheme of things.
Yeah, but this is a big debate. We can't talk on like one-to-one.
I think we should give the case to medical oncology. He should decide whether surgery should be done or radiotherapy.
No. That final decision should be with the patient. If patient is comfortable with the surgery, then that should go with the surgery. If patient is more comfortable with non-invasive procedure, radiation, then that should be go with the radiation. That is the final. Patient comfort should be the topmost priority.
Patient should be given the
Let's say Mathu sir has a question.
Thank you very much for the elaborate talk on the radiotherapy. You have mentioned the various modalities and newer techniques. So my question is about CA prostate. I've shared it with the 2 patients whom I know. One has gone for surgery, another has gone for hormone therapy followed by radiation therapy. Now, the outcome of the surgery patient, he got it done is surgery for already from the medical center. He still has urine incontinence. What 4.5 hours will pass. The person who was gone for the hormone therapy followed by radiation therapy, he is, I think, completely better. He has not any problem right now. So choice between them is a patient-centric, you rightly said. The patient has to be aware of every possibility in the treatment and effect of treatment. Like we used to call a cancer board, where the oncologist and the all three disciplinary surgeon, medical oncologist and radiotherapy should also be there. And that is the decision to be taken at the board. In which is the better treatment modality available to the particular patient. As rightly said, patient-centric is. So what is the role of cyberknife?
So cyberknife is not for the mainly for the prostate as such. Cyberknife is one of the instrument, one of the like image where we can treat if for 6-dimensional some other things we need, so for the especially for the spine SBRT we need for the brain, where non-coplanar beams we need to put. So it is one of the like one of the machine which can treat the patient but with different angles, like it's for that. So if I want 6 machines for the radiation, then I think for the cyberknife. But overall, right now cyberknife is completely out of picture, because instead of cyberknife also I still prefer gamma knife. So gamma knife is still better, because in gamma knife I can treat even 40 odd tumors, lesions in the brain, but not in the cyberknife.
Restrict to the prostate cancer only. So cyberknife is not much of a
yeah, that because cyberknife we don't require, we can do on our normal image. Why for the cyberknife?
The last question.
Sir, just to add, the way we say na, इसका Xerox करा के लाओ. Xerox is the company's name, Modi company, it's a photocopy. Cyberknife is a company's name. The actual technology is SRS, stereotactic radio surgery, through radiation. Am I right?
Yeah. For that.
I was not aware. Thank you, sir. Thank you. The cost of a plant radiotherapy in a case of prostate cancer not, move further, remain localized in the cancer area.
In your setup, the cost of radiation.
Cost of radiation.
Number of readings.
Yeah, so cost of radiation comes in between the range of 3 to 3.5. If we compare the same worldwide, so it is just 1/4 or 1/5 as compared to the US, UK or anywhere. Very less.
Delhi.
Compared to Delhi also, Delhi we have the least. If you send the patient to Max, they charge around 4 lakhs. But the same thing is the Batra have like over the same. But for Batra charge, we also charge the same only. That I know.
Can you you are the cheapest, you are the best?
No, I am not the cheapest. I am not the cheapest.
Economical.
I am not the cheapest.
Dr. Vikas, so I have a case for you and for my panel here and for everyone's attention here. So it's a 52-year-old person, and Dr. Amish and me have been working on this for some time. His CT of the paranasal sinuses, coronary angle. This is a operated case of a cellular pituitary adenoma in 2005. It was removed by Dr. Rana Padir. At present, this person presented with certain nasal symptoms, and he was seen in your hospital in Manipur by one of your ENT surgeons. A large, well-defined, heterogeneously enhancing soft tissue mass is present in the sphenoid sinus, predominantly to the left from the midline, having heterogeneous enhancement with smooth erosion and destruction of the adjacent clivus and sphenoid bone. The mass is completely opacifying the sphenoid sinus, extending into the left nasopharynx, causing complete obliteration of the left nasal cavity. The posterior nasal cavity is completely obliterated by the mass lesion. The approx maximum diameter of the mass is 4.5 centimeter. The left internal carotid artery is encased by the mass lesion. However, no luminal compromise is present. Nasal septum is in midline. Nasal tabulates are normal. Right nasal cavity is normal. Bilateral maxillary sinuses are clear with patent both osteometal units. No mucosal thickening or fluid level is present. Both ethmoid sinuses are clear, including both anterior and posterior ethmoid layer cells. Both fronto-ethmoidal recesses are present. Frontal sinus is clear with thin complete bony spurs. No mucosal thickening is present. No olfactory grooves. The olfactory grooves show ketos type 2 morphology. Bilaterally. Yeah, solo yeah. The optic nerve show Delano type 2 morphology bilaterally. CECT PNS features, yeah, रुक जाओ यार 2 मिनट रुक जाओ please. The CECT PNS features are suggestive of heterogeneously enhancing soft tissue mass involving the sphenoid sinus slightly to the left from the midline with associated complete opacification of the sphenoid sinus and the mass extending into the left nasopharynx. I discussed with Dr. Amish, and Dr. Amish said that the immunohistochemistry come. It came from Dr. Mahajan's lab. It was a pituitary endocrine tumor. I sent the report to Dr. Amish, and Dr. Amish said that we should send it to Dr. Jay Mehta, and we sent it to Dr. Jay Mehta, lineage pituitary endocrine tumor. I want your opinion on this patient. Surgery for debulking or surgery followed by radiation or surgery followed by radiation and chemotherapy. What is your advice?
So if it is a neuroendocrine, pituitary neuroendocrine, so definitely there will be a role and it is restricting to the bone restriction is there. Pituitary neuroendocrine, so first my medical oncologist will try to do some systemic and then surgeons will going to operate it to debulk and then followed by the
first chemotherapy, then debulking.
Yes.
Or debulking, then chemotherapy.
So neuroendocrine is always better to go with the chemo point of view first.
Sir, your opinion, Dr. Amish?
बहुत रहे टाइम ऐसा था मेरे पास भी माइक है. So it's actually there are two. It's a very funny and interesting topic because I also read into it. It's a keep it positive neuroendocrine tumor with Ki67 of 1 to 2%.
1 to 2%.
Ki67 is 1 to 2%.
Ki67 आपने बोला.
Ki67 1 to 2% का मतलब ये है कि कैंसर के एक सेल से 2 सेल होने में 6 महीना भी लग सकता है, एक साल. So I read and I came across one of the case report which was untouched, and for 10 years the disease in progress. A cancer which is full entire nasal cavity is blocked going up to cavernous sinus and you don't do anything. कौन सोचेगा ऐसा? That is one. Second thing is you need to do an entire hormonal workup from testosterone to LH to FSH to prolactin. If it is a growth hormone secreting tumor, you give anti-growth hormone and the tumor will shrink. So that is one side of the spectrum. The other side of the spectrum, if it is not secreting any of the hormones, first neurosurgeon, it can be operated upon completely. If can't be operated upon, and if there is no hormone secreting, then the role of radiotherapy comes. The role of chemotherapy is the least because it is a very slow growing tumor. Most likely 2005 से ये रीग्रो करना शुरू किया था और 2026 21 साल बाद भी यहाँ पे है. पेशेंट को ज़्यादा प्रॉब्लम नहीं है, वो जैसे नाक भर जाता है बस.
Thank you, sir. So, sir, is any in your practice Ki67 come more than 30%? for the same type of tumor, then what you will.
Sir, how many cycles of, I want to ask you, how many cycles of chemo before you referring for debulking?
So right now, this patient is not a candidate for chemo. Period. Chemo काम ही नहीं करेगा.
This patient,
If कोई growth or please.
since the tumor is very large, encasing the internal carotid artery going to cover the sinus, so completely surgical removal is not possible in this case. So what first?
Thank you for asking this question. Let him first answer, then I'll answer. Sir, it's a different topic altogether, and I would say is that unproven, unconventional things बाद में करें. Sir, 46-year-old OT technician in a government hospital deserves something better. Sir.
Absolutely, agreed sir, agreed. And Dr. Amish Vora knows the entire issue. Dr. Dulci sir.
So, after those very complex questions from our colleagues, I have two simple questions for Dr. Vikas and two simple questions for Dr. Amish. Let me begin with you, sir. So, ASTRO last month, 2026, at Stockholm, talked about the Cmes trial and the Adelaide phase 3 trial. Talk us about these two landmark trials. Sir, the ASTRO last month. Okay. Amish, would you like to take that?
सर अभी ट्रायल का नाम याद नहीं है. आप थोड़ा और बताओगे तो मैं आपको बताऊंगा.
So, European Society of Radiotherapy and Oncology trial. This was just May 2026. Talked about two landmark trials. One was regarding the Cmes study, and the other was the Adelaide trial, phase 3 trial.
Is this about proton versus photon?
No, sir.
Okay.
So,
तो थोड़ा सा इंडिकेशन दो ना, तो मुझे याद आ जाएगा. ऐसा नहीं सर मैं रेडियोथेरेपिस्ट नहीं हूँ.
you're more than that. Anyway, so Dr. Vikas, we're talking about the Cmes trial. We said that you see, shorter prostate cancer regimen radiotherapy, just 2 high doses over a period of 8 days is much better than a prolonged 5 to 10 radiotherapy sessions. This was regarding the Cmes study on prostate cancer.
Right now, but we are practicing this since long. It's more than 5 years we are practicing. That is called SDRP or ultra hypofractionation.
So,
we treat in 5 sections.
Yes, you treat in 5, but here they talked about just 2.
Yeah, so
they said 2 probably is better than 5.
Yeah.
This was the recent study, the large study. Anyway,
yes, but thing is that to do that thing, that perfectly to achieve, the rectum should be completely empty and bladder should be completely filled. So in Indian setup, still we are not doing it two fractions. We are taking in 5 only. That also when we see the patient compliance for that, then only we will do that.
I'm sure. Sir, अब मुझे याद आ गया. 1 minute, sir. 1 minute.
Good.
Now, because I said since I'm not a radiotherapist, I need something.
You're more than that.
Cmes trial is a phase 2 trial. First of all,
No.
Sir, it's a phase 2 trial. Sir, trust me, sir. It's a phase 2 trial. अभी आया है. 2 fractions versus 5 fractions. How they divided into that.
Absolutely.
And low risk, intermediate risk and intermediate favorable. Sir, ये इन्होंने cover किया. Right. Their whole idea was the side effect reduction, but efficacy should be the same. So that is what they said. Actually, the side effect reduction was almost comparable.
Yeah.
Low fraction में आदमी खुश हो जाता है. So it was a good thing. But sir, it needs phase 3 trial before we can adopt it. I think radiotherapists are still doing 5 fractions and not 2 fractions.
So this study talked about just 2.
Yeah.
2 versus 5.
Sir, I just said, for external beam radiotherapy, we are doing with 5 all over India, just like that. But if we want to treat in single or 2 fractions, we treat only with brachytherapy. That is limited to only very low risk and low risk. We don't treat intermediate risk also with braking.
Okay.
That is a monotherapy, that is a NCCN guideline. As per the NCCN guideline, ASCO guidelines, we treat that. So 5 fractions or in two sittings also, that is to the brachytherapy,
Right.
not to the external risk.
Let me proceed further regarding the adrenaline trial. Dr. Amish will know about it probably. So ART as good as ALND for outcomes, for oncological outcomes. Better patient outcomes. Talk us about this. Dr. Vikas? The adrenaline trial presented at the EBCC.
Sir, you are talking of lymph node dissection.
Axillary RT versus axillary lymph node dissection.
Correct.
After neoadjuvant cancer breast therapy.
So that also regarding if axillary dissection is already done, we don't touch the axilla. We are talking about the CFS. So we don't touch axilla if already sufficient axillary dissection is done. Only in case axillary dissection is done but tumor burden is more. For say out of 20 tumor, 20 lymph nodes, maybe 5 present or extracapsular extension is there, then we have, otherwise we leave it because it may cause lymphedema. There are very high chances.
But I think what Tulsi sir is saying is right. Sir, I got your point. Very interesting point, sir. Up till now, what was the practice? You do a sentinel lymph node. 2 से ज़्यादा आया, आपको axillary lymph node dissection करना है. What this trial did was that even if you have more than 2 lymph nodes, don't go further with surgery, do radiation. And that is what it should be. The ART
is as good, probably superior.
Correct, sir. It's a very interesting thing.
And lymphedema was much less.
Much less, sir. Very interesting thing.
Any phase 3 trials about
This is phase 3 trial. The adult trial is a phase 3 trial.
There are Amish trials and other trials which prove that treatment.
This is just a month old. Anyway, let me proceed. Oh, you have to say something? Yeah.
So it totally depends on our surgical. It totally depends on our surgical practice.
No, I have 2 questions for you.
About this, it totally depends on our surgical oncologist practice because if they are ready for that, then only we can do it. Otherwise, most of the patients come with the axillary dissection only.
Okay, so Dr. Amish, so talk us about the divarexin, the latest drug for multi-selective. So multi-selective RAS inhibitor for pancreatic cancers.
सर आज मेरी किस्मत अच्छी है क्योंकि ये मैं नेक्स्ट मंथ में वेबिनार कर रहा हूँ. सो डाराज़ोनरासिब इज अ ड्रग्स नेम. डाराज़ोनरासिब मुझे भी 4 बार प्रैक्टिस करना पड़ा था. दैट टाइम आई केम टू नो 40% of pancreatic cancer have a mutation called KRAS. उसमें भी KRAS 12 exon 12 में सर. So daraxonrasib is a KRAS 12 inhibitor. It has been tried in second line prostate cancer. तो first line में आपने कीमो दिया, टारगेट दिया, patient responded, then patient progressed, then comes the daraxonrasib versus second line chemotherapy. The survival is double with daraxonrasib compared to chemotherapy.
I am talking about pancreatic cancers.
This is pancreatic cancer only, sir. New England Journal of Medicine article. Absolutely, sir. आपने पढ़ के आया हूँ.
Sir, I'm usually the last person. Let me ask 2 half questions, sir. Sir, single dose radiation therapy, it came in the social media when Arjun Rampal's mother got it first. It was very much highlighted, I think 5 years back or so. So are you practicing single dose radiation therapy?
We are doing that is called as if we do in brain. If we do outside brain, then that is called as SBRT. We are doing for many. For the spine also we are doing single fraction. We are doing for the brain also, and in the radiation still we are doing for the single fractions.
And what about liquid radiation therapy? Liquid radiotherapy.
Liquid
liquid radiotherapy, like we give isotope for the thyroid.
Okay, it's a kind of a vibe also. I feel
Glutathera is the new one coming
So
from.
Dr. Vikas, I'll tell you one thing. This is very good about this group.
yes.
You go and do CMEs in thousands of places.
Yeah.
But scientifically enriched group यहाँ पे जो है ना,
That's
you imagine I travel 35 weekends per year. लेकिन तुलसी सर जब होते हैं ना, actually पढ़ के आता हूँ कि सर कुछ ऐसा सवाल ना पूछे जो मुझे पता ही ना हो. But honestly, it's a very scientifically enriched group. यहाँ सिर्फ लोग खाना खाने वगैरह नहीं आते, they come to learn.
So we also feel delighted for that.
Sir, let him answer.
So sir, we also feel so delighted for that because even nowadays when we go for our academic kind of so-called CME or conferences, there also we are not getting any much of the things. So somehow I complete lose of interest in all that. If somebody is asking, then it's again give us a kick to read more, to come with more.
We learn from each other.
Yes, so it's very great.
Sir, why you are using this brachytherapy and what is the medical material you are using in it?
Brachytherapy for?
Brachytherapy किस में?
What is the concept of it?
So concept of brachytherapy is it is very precise. There is no chance of any scatter dose for the brachytherapy. Brachytherapy means some radioactive for say iridium-192 we use. So that goes near to the tumor and radiation is given. So that just goes to that tumor only. It don't go somewhere else. So we can give intracavitary, we can give intraluminal, we can give during the intra-op. So there are different type of brachytherapies. By this we can. So only to the point.
किस कैंसर में ब्रैकी का?
So we are doing it is an integral component of CS cervix. After giving external beam radiation, we go with the brachytherapy because we can't give such high dose of around 80 gray from outside because there is some tolerance constraint for the rectum and the bladder. So we give around 45 gray from outside, then three sessions of 8 grays each that we give through internal. So that is like one most commonly we use. Intraluminal like for the CA esophagus where surgery is not possible after giving external radiation of around 50 gray, we give 1 or 2 sessions of intraluminal also. Esophagus. We give same thing to the for biliary tract. If possible, we try to give after putting BTBD, we try to give intraluminal brachytherapy to the biliary tract cancers also. We give brachytherapy. I am not treating the prostate one because it feels so convenient for me to treat by external beam. So I am not practicing that. That one of my friend at Vedanta, he is practicing in Delhi for brachytherapy for the CA prostate. If anybody asks me, you know, यहाँ में prostate में brachytherapy चाहिए तो मैं उसके पास ले देता हूँ यहाँ because it's not possible to treat all the things.
Approximate cost?
Cost for the brachy cost comes like if I treat CS cervix, so brachy cost for one session come around 1.5. It's very high. Why? Because of the admission, IPD, for the anesthesia, for the nursing, this, that. But the cost of the one session of radiation is only 20,000. But other cost of 24-hour admission, this, that come almost around 1.25 to 1.5. So it comes very costly.
Dr. Amish, Dr. Pandey and Dr. Vikas, thank you for a wonderful session. Can you just summarize it for us? Just the carry home message.
Radiotherapy is an integral part of oncology treatment. One. Second thing, at many cancer sites, you cannot avoid radiotherapy if you want to do a complete cancer treatment. Selected properly, radiotherapy can replace surgery. With the newer machines of radiotherapy, the side effect is much less and the effect remains the same. And third is trust your radiation oncology colleagues to cure your cancer patients well.
Thank you, Dr. Amish. Coming from somebody who very well compliments a radiation oncologist, we thank you for your presence.
as well as Dr. Pandey and Dr. Vikas for being present, and Dr. Munshi sir for making all the efforts for making this possible. Thank you, Vinay. Thanks a lot for doing it for us. I request all of you to please have your dinner before you leave. Thank you. Amish.